One other factor is always brain coverage. Obviously, the disease is highly prone to intracranial manifestation.
So, Martin, let's start by laying some groundwork. Could you briefly summarize CLEOPATRA and essentially the current standard of care and the first-line treatment for metastatic HER2 positive breast cancer?
Dual inhibition of HER2 with trastuzumab and pertuzumab and underlying chemotherapy backbone self-limiting with a taxane. This has been the standard of care for over a decade and really has not only given us an improvement overall, but a continued improvement with each long-term time point. So the dual inhibition of HER2 was really the long-standing standard of care for our patients. We've seen the curves dividing up further. There was an initial concern, but obviously the longer we moved out, the more we learned about this. And we think about some of these responses as really durable or maybe permanent. So quite a leap forward compared to where we were before treating HER2-positive breast cancer. But it's always nice to see new data evolving. So I'm looking forward to the discussion.
Yes, absolutely. Well, and I caught how you mentioned the current versus past standard of care because the landscape is changing so quickly. And before we get to some of the new data that you alluded to, I think we certainly acknowledge the incredible impact that CLEOPATRA has had, especially with the 8-year long-term follow-up data. But I want to ask you about current unmet needs, or at least with the CLEOPATRA paradigm. What do you see as the pressing unmet needs in the care of our patients in this setting?
Well, I think there are a number of factors. I think one is the durability. We've had about 18 months progression-free survival in CLEOPATRA. I think there is some question about durability in these young patients. That is an important one. One other factor is always brain coverage. Obviously, the disease is highly prone to intracranial manifestation. So having coverage here in dual ways is very important. And obviously, developing subsequent line of therapy standards that will be able to sort of extend the benefit that we're seeing. And obviously, with DB01 and DB03, we had some data that really heralded that we have post-progression therapy that's able to overcome some of the resistance that we're seeing. The HER2 amplification is a very stable genetic alteration, so this remains a potential target all through the course of those treatment lines. So I think those were the main ones. So I would say durability and brain metastases are probably the two pillars that I would like to work on the most.
That makes a lot of sense, absolutely. And I think that diving a little deeper, what are your thoughts about the management of adverse effects or areas of need there? I think the CLEOPATRA regimen, we certainly deal with the toxicity of taxanes, and really, of course, any therapy has toxicities that we need to manage. But how has this impacted your patients in terms of the duration of therapy and how that translates to toxicities related either to the taxane or to the regimen as a whole?
Yeah. I mean, obviously, it's a self-limiting regimen. The neuropathy is clearly impactful, and the longer you think about survival, the more pressing the issue seems that we really have to cut back and cut out with taxane backbones. The other question is GI toxicity, especially with pertuzumab. I think that has always been a discussion for us, how well we can manage this. I think there are other side effects that we monitor, but I've gotten quite comfortable with contractility of the myocardium as a sort of an on-target effect of HER2. I think that's important. But I think overall the regimen was pretty well tolerated, especially as it moved into the maintenance space. So it was definitely a leap forward for us.
Absolutely.